Hey everyone, hello again from Dr. Prepper. I'm back with another question for us to discuss and some more topics we can look into. And these is what will help you answer these questions better in your NEET exam, which is not so far now. So let's look at today's topic and let's dive into today's discussion. Let's go get you that PGC.
So the question we're going to talk about today is which of these is not a hormone regulating calcium metabolism? So the options are calcitonin, parathormone, vitamin D and calbindin. So the correct answer to this question is actually D, that is calbindin. Now a lot of you will want to argue that how is vitamin D not the correct answer because it is not technically a hormone. But what I want you to remember is vitamin D acts like a hormone when it comes to regulating calcium metabolism. I know it is a vitamin, but it has hormonal action when it comes to regulating calcium metabolism. Why calbindin is the right answer? We're going to look into the concepts right now. So the topic for today is calcium metabolism. So calcium is present in our body in three forms. Combined with plasma proteins, which accounts for 41%, combined with other anionic substances, which accounts for 9%, and 50% of the body exists as free ionic calcium, the calcium 2 plus or the calcium plus form you see. So ionic calcium is the one responsible for all of its functions. So you often get this question also as to which form of calcium is responsible for all the functions, and you must remember that ionic calcium is the one that is responsible for all these functions. So how does this calcium come into our body? The most common and the wide range of the source is from intestinal absorption. We get about 1 gram or 1000 milligrams per day of oral intake. That's roughly the calcium in about 1 liter of milk. So I don't think anyone drinks that much milk, but that's the equivalent to just to give you an idea. Vitamin D obviously increases absorption. About 350 milligrams per day is absorbed and 250 milligrams per day is secreted in the GI secretions. Almost all of the dietary phosphate that we take in is usually absorbed. So you remember calcium and phosphate metabolism usually goes hand in hand. So all of the dietary phosphate is absorbed and about 350 milligrams per day of calcium is absorbed. How does this calcium leave our body? So calcium is mostly excreted out through the kidneys. About 100 milligrams per day is excreted in the urine. Only ionic calcium diffuses through. So if for some reason the calcium is attached more to the anionic substances or to the proteins, then that will not be accounted for in the renal excretion. 90% of the calcium is absorbed back in the tubules in the PCT or in the DCT, as you know. Not mostly in the DCT, mostly in the PCT is where the calcium is absorbed. You should remember that. 10% is variable, affected mostly by PTH. So where vitamin D acts mostly on the oral absorption of calcium, you must remember that vitamin D affects the oral absorption. So PTH affects mostly the renal excretion. So they cause effects in both places, but the predominant effects are in different places. Phosphate is basically an overflow. When you have enough phosphate, the remaining is excreted through the kidneys. Very simple to understand. So now we're going to talk about vitamin D, which is as you know, it always goes hand in hand with calcium, most important hormone. So this is the pathway of formation of vitamin D. You must remember that vitamin D undergoes two activations to become its active form. So the first activation is in the liver, where the raw material of cholecalciferol becomes a hydroxycholecalciferol. So this right now has two OH groups. It's a diol. The second activation happens in the kidneys, where it becomes 125 dihydroxycalciferol. Remember, it's dihydroxy, but it already has an OH group. So here it has 3 OH group, or it is a triol. So triol, therefore, this is an active form of vitamin D. This is also known as calcitriol, which is the active form of vitamin D. So you can get questions from any of this, which is the active form of vitamin D. You can get calcitriol or this. How many OH groups does it have? Where do the activations occur? You must remember all of this. So let's look into how they go into affecting the calcium metabolism. So vitamin D mostly has receptors on nuclei of most of the cells. It combines with something called a retinoid X receptor. Just for sake of objective question, the affinity of this receptor is the highest for 125 dihydroxycholecalciferol, which we already discussed, as also known as calcitriol. So that is why this is the most active form, is because the affinity for the receptors is the highest. It's about 1000 times more than the previous form, the diol form. So the diol also has an action, but 1000 times more is the action of calcitriol. That's why it is the most active form of vitamin D. So how does vitamin D affect the levels of calcium in the body? First of all, it increases the formation of calbindin. As you remember, this was the answer of our question. So calbindin is basically a protein. It's a protein found in the intestinal lining of our gut, and this is what increases the absorption of calcium. So more amount of calbindin that you have in your gut lining, it leads to increased absorption of calcium. That's how it works. It's a directly proportional. So calbindin is only a protein. It is not a hormone which affects calcium metabolism in any way. It just is a protein that picks up calcium from the gut and brings it to the bloodstream. So vitamin D increases the formation of this calbindin and therefore increases the intestinal absorption of calcium. It also decreases renal loss of calcium by increasing its reabsorption along with phosphate from the tubules. So it increases the reabsorption of calcium and phosphate from the tubules. It decreases the renal loss. If you get a question saying which is the more prominent effect of vitamin D, it is the oral effect. The oral effect of vitamin D is more, the effect on the kidneys is much lesser. So these are the two main ways. Both of these will result in increased calcium in the bloodstream. So the next hormone we have to look at is obviously parathyroid hormone. I'm sure you all have heard about this. So what this does is, the main action by which this increases, this also is mainly responsible for increasing calcium levels in the blood. So how does it? Stimulates bone resorption. So it basically causes bone to thin out and causes them to release calcium into the blood. It also increases calcium reabsorption and decreases phosphate reabsorption from kidney. So that's a very important difference between parathyroid hormone and vitamin D. Vitamin D causes reabsorption of both calcium and phosphate. Parathyroid hormone causes increase in calcium reabsorption but decreases phosphate reabsorption. Another way in which it helps in increasing the calcium levels is it contributes to activation of vitamin D. So you can get this question also, which of the following actually contributes to activation of vitamin D also as one of its action? That is PTH or parathormone. So overall, by all these actions, it is responsible for increasing the calcium concentration in the extracellular fluid or in the bloodstream. Like every other pathway in the body or like any other thing that requires regulation, the parathyroid hormone action also has a feedback mechanism. So there is something called a calcium sensing receptor or CASR in the parathyroid cell membrane. This stimulates the release of calcium from intracellular stores. So if this receptor senses a decrease in calcium, it will cause release of the calcium from the intracellular stores, also decrease PTH secretion. Let's just go into the details of that a little bit. Okay, so this is a pictorial representation of how the feedback mechanism works. Like I told you, there is CASR or calcium receptor, which decreases a decrease in the level of calcium, therefore cause an increase in parathyroid hormone secretion. This will cause increase in bone resorption, increase in calcium in the blood. It will also affect the kidneys. Like I said, it's the main way in which PTH affects is the kidneys. So it will increase calcium reabsorption and decreased phosphate reabsorption. By activating vitamin D is how this parathyroid hormone will cause increased calcium absorption from the intestine also. So three-pronged approach, one indirect, two direct, and it will overall cause an increase in calcium levels. So when this increase in calcium levels will happen, there will be a feedback which will cause decrease. So in one way, this pathway is very different than other endocrine feedback mechanisms in the sense that usually an increased level of a metabolite leads to decrease in production of a hormone. That's how it usually works. As you know, in case of thyroid hormones or other such hormones, but in this it's the reverse. It's usually the decreased concentration of a metabolite causing the increase in hormone secretion. So that is one thing that is different. I don't know if a question can come from that, but you should know that important concept. It is usually different than other endocrine pathways. So an important concept I want to introduce you guys to right now is a way in which the parathyroid hormone acts is basically how it causes resorption of the bone. So why I want you to understand this pathway is a lot of recent advances in orthopedics and treatment of osteoporosis and other ailments is actually based on this pathway and the action of the parathyroid hormone. So this is called the rank L or the OPG pathway. It's called a rank L OPG pathway. So what they stand for, let's look into that. First is two proteins. So rank is basically receptor activator for nuclear factor K ligand. So that's what rank L stands for. OPGL or OPG stands for osteoprotegrin. So now that we know that. So the receptors for this, they usually affect osteoclasts. Okay. But osteoclasts, as you know, are cells that cause resorption of bone. They release calcium from the bone. Osteoblasts, on the other hand, are cells which lay down new bone and therefore increase calcium deposition in the bone. Now, what's very important to remember is the receptors for these, even though the action is on osteoclasts, the receptors are actually on osteoblasts. Very important. The receptors are still on osteoblasts itself. So when these receptors come to the osteoblasts, they cause release of this rank L or the rank ligand. So what that does is it contributes to formation of osteoclasts, and that will cause resorption of the bone. So how does PTH affect it? This is a normal pathway that goes on. So how does PTH affect it? PTH binds to an adjacent osteoblast and stimulates production of this rank L ligand. Okay. So the rank ligand is produced by these osteoblasts and PTH increases that. And what it does is it binds to rank receptors and converts precursor cells to mature osteoclasts so that they can dispose of their function. What is the function? As we know, resorption of bone. So PTH causes increase in rank L binds to the rank receptors, and that converts the precursor cells into mature osteoclasts. I hope you've understood all that. Let's look at the next part of this. So now that I've told you about how rank L is, you will ask me, so what does OPG do? So OPG is osteoprotegrin, which basically prevents these rank L ligands from binding to osteoclasts. So OPG is basically antagonistic to rank L. If the rank L is produced and there is OPG production to block, like as you can see, this has bound to the rank L and blocked it. So if it has blocked it, it cannot bind to the osteoclast precursors and convert them into mature active osteoclasts. So that's what you need to understand. OPG inhibits bone resorption by binding to the rank L. Rank L stimulates bone resorption by binding to its rank receptors. As you can see, it's on these osteoclast precursors. These are the receptors. So rank L wants osteoclasts to mature and cause bone resorption. PTH, by increasing this rank L, stimulates bone resorption, as you can see here. But OPG inhibits this bone resorption by binding to the rank L and preventing them from disposing of their function. So as you can see, this is the common, like the whole pictorial representation of how this entire pathway works. So now I want you to keep this in mind so that next time when we discuss the different drugs that affect this pathway, we can it will be easier to understand. So now we'll discuss the one hormone that actually decreases the concentration of calcium in the blood, decreases serum calcium levels. That is calcitonin. So calcitonin is released by the parafollicular cells, also known as C cells in the thyroid gland. Remember that, very important. So it is an opposite or antagonistic action to PTH. It decreases the concentration of calcium. The effect, you remember, is very weak as compared to vitamin D and PTH. So this causes decrease in calcium levels. It makes the calcium go and get deposited in the bone. So this has a negative feedback mechanism where increased plasma calcium concentration stimulates the secretion. So that removes this calcium and deposits in the bones. It has a weaker feedback than PTH, very important. Decreases calcium concentration in the plasma, as you know. It decreases the resorptive action of osteoclasts and the osteocytic membrane also. So that other action that we saw, PTH increasing the osteoclast activity, this decreases that activity. It also decreases the formation of new osteoclasts. So you might think that it causes increased osteoblastic activity, but no, it primarily acts on the osteoclasts and causes decrease in their action, therefore making sure the calcium stays in the bones. So now that you've understood all these concepts individually, just a brief overview of how the entire calcium homeostasis is maintained. So we'll start from this side. The blood calcium level has decreased. You need more calcium in the blood. It stimulates the parathyroid glands through the calcium receptor. It causes increase in PTH. which stimulates calcium release from the bone through its osteoclastic activity through the rank L and rank L pathway that we talked about. It stimulates calcium uptake from the kidney, and it also activates vitamin D. What does that do? It increases calcium absorption from the small intestine. All of this causes an increase in calcium level in the blood. What happens when blood calcium level increases a lot? There is rising calcium level in the blood. It goes to thyroid glands through the parafollicular or C cells. Calcitonin is released. It stimulates calcium deposition in the bone. It reduces calcium uptake, reduces osteoclastic activity over here, and therefore causes a decrease in the calcium. So this is actually a decrease. So here there will be a decrease in calcium levels. So that decreased calcium. So this cycle keeps going on and on. PTH plays a role, calcitonin plays a role, and vitamin D plays a role here also. Very important to remember these three hormones. Vitamin D, being a vitamin, also has hormonal action on calcium metabolism. Do not get confused with that. So the three main hormones that regulate calcium metabolism become PTH, vitamin D, and calcitonin. Based on their different levels, you can have different kinds of metabolic bone diseases. There have been a lot of recent advances which target these pathways and their individual mechanisms, which are used nowadays in therapy. There's a lot of things to discuss. Next week, we're going to discuss the drugs or the recent drugs that have come up, which target these pathways and help in treatment of osteoporosis. So we shall discuss that soon. We shall also go into their different levels and the different disorders of hypercalcemia, hypocalcemia, and other metabolic bone diseases soon. So there's a lot more to discuss.
So that's all we have for today's discussion. Hope you liked the video. Corroborate that by hitting the like button. Share this video for some of your peers who might benefit from such content, and subscribe to the channel if you want to continue looking at discussions regarding clinical topics. If you want me to discuss any particular topic, please let me know in the comment section. So all the best. Keep up the good work. See you next week. All the best for your NEET.